if you want, Sarah. So everyone will kind of just come back and, you know, get situated after their break. But really excited to hear your talk on ADHD. Many of you probably know Sarah from her time as a chief last year, but for the interns and those of you who don't, she's currently one of the attendings at Roosevelt at GIM, and we're really excited to hear from her today.
Yeah, thank you, Lauren. I hope this is helpful. This talk came to be after we realized this past year at Roosevelt how many of our patients come in looking for an evaluation for ADHD, and how basically we have no one to refer them to help us make the diagnosis. And I really like taking care of folks with ADHD and really interested in the diagnosis of ADHD, so I thought maybe I'd put together a talk to help you guys feel a little more comfortable with that. So yeah, my goal for this talk is to help you not be afraid to manage ADHD as an IM resident, regardless of which clinic you're in. And we're going to do this specifically by talking about the different ways to diagnose ADHD without psychiatric help in just a 20-minute visit in clinic, and how to essentially choose and prescribe between ADHD meds. And while a fair amount of this talk is a little bit lecture-based, I would really love it if you guys feel free to interrupt me at any time, either with questions in the chat or just to come on with your audio, because again, this is meant to be helpful for you. So if I'm not addressing your questions, please bug me to address them. So we're going to start first with some poll questions, but if anybody sort of wants to know a great funny resource for ADHD, there's this wonderful online comic who does the ADHDalien.com, where she describes what it's like to have ADHD versus what it's like not to have ADHD in really funny ways, and I highly recommend looking her up. She has like 15 or so comics that are really fantastic. Okay, so we're going to do a poll here first. And the first one I would like you guys to answer for me is whether or not you feel comfortable accurately diagnosing a patient with ADHD. So this is some pretty interesting initial data. Can you guys see that here on your screens? Lauren, is that visible? I haven't done the poll myself. I just want to make sure that people can see it.
It's visible to me, but I think I'm co-host, so I think it should be visible to everyone. But chime up if it's not, guys.
So it looks like the majority of you guys disagree or are neutral, with some strongly agree. It sounds like nobody feels comfortable diagnosing ADHD. And then for the next one here that I want to ask you guys is, oops, it's frozen in my screen here. Bear with me one second while I recover my poll thing so I can see it. Is whether or not you feel comfortable managing medications and choosing an agent for folks with ADHD. So it looks like a initially fairly similar spread. We've got 6 folks in the program that feel pretty good about it, but it seems like, again, most people here are not regular prescribers of ADHD. Okay, so hopefully we'll make this a little bit better by the end of today's session. What we're going to start with first is a case. This is a real case of a patient of mine. This is a 25-year-old man who was referred by his counselor for evaluation of possible ADHD. So my question to you guys is, if this is the patient coming into your clinic, what do you want to ask him as part of your HPI? Would you guys be willing to throw some stuff in the comments? I have lots of social history if you guys want it. Let's see, Megan. History of ADHD as a child. Ooh, good question. He's not sure. He was never formally diagnosed, but his mom was suspicious that he might have had ADHD based on some of his behaviors in school. Let's see, Mac is looking at DSM5. We'll come back to that, Mac. DSM5 is not super helpful. Christian, what symptoms do they have? How long have you had them for? And what settings do they occur? Let's see, Anisha asks about academic, Catherine substance use, settings from Alex, yeah, really good point. let's see, Alex Torres, what made the counselor concerned in the first place? And Shiv gets some collateral, always a good call. You guys are spot on. I don't think you need me to teach this. So this gentleman, a little bit about his social and academic history is that he started college actually at 17 years old. He graduated early and enrolled at Seattle University. And unfortunately for him, he actually immediately failed his first quarter. He only passed with like 100% his calculus class, but failed all of his humanities courses. Was basically enrolled for the next year, more or less on probation, but always struggled to complete his assignments, really had a hard time with reading and writing papers, but always excelled on his tests and his more math and science-based class. Really, by the time he was a sophomore, he went to India as part of a school trip, ended up dropping out, and then basically just lived in India for several years, volunteering, working irregular jobs, really just couldn't find consistent employment. Came back to the States eventually, worked as a general contractor, got bored by that, and was like, well, maybe I'll go back to college. So around the age of 25, he went back to college to finish a science degree, and essentially all the same issues came up. He was getting really anxious and stressed, so his counselor sent him essentially in for evaluation for ADHD. He basically told us that his study habits were quite variable. He said he never really had trouble with school, but he could only be excited about topic or assignments that he found interesting. And if they weren't interesting, he'd always wait to the last minute, often staying up all night to finish assignments, and even then, sometimes not making deadlines. He always functioned best when he was sleep deprived, when he medicated with tons of coffee or tobacco, and exercise was a big coping mechanism for him. Again, I just sort of wore him out. He had a lot of issues with organization and completing tasks, maintaining some degree of routine, and even just doing his ADLs. He would always lose track of time and forget appointments, even classes. He was constantly fidgeting as a way to cope and often interrupting or distractible. And again, with this, he had a lot of anxiety around his behaviors, not really knowing why he couldn't be more like his peers, and particularly feeling quite depressed when people were like always frustrated and disappointed in him. So a little bit about the history of ADHD. So this is actually George F. Still. He was the first physician to mention ADHD in 1902. And he described it as an abnormal defect of moral control in children, specifically noting that the affected children could not control their behavior the way a typical child could, but they were often still quite intelligent. And what's really interesting actually is there were no medications for ADHD until about 1955 when Ritalin first came out, and the DSM didn't even recognize it until 1968. So it's actually fairly recent within our medical community. Currently, the most recent statistics say it's about 4.4% of adults between the ages of 18 and 44, but rarely sort of studied in the older population. For those that are diagnosed as children, about 50% go on to have it as adults, and that's not really accounting for those that weren't diagnosed as children who then present as adults with symptoms. There's definitely a genetic or sort of familial association. It's helpful to ask family history here because a lot of them often have parents or siblings with ADHD. And it often comes with a lot of comorbid psychiatric disorders. So mood disorders can be as high of an odds ratio of 7.5%, anxiety 5.5%, and substance use is really common in these folks. They have some of the higher psychiatric illness associations with substance use disorders. People with ADHD, it's really important to sort of figure this out because they often have higher rates of occupational difficulties, criminal activity, substance abuse, and even things like motor vehicle citations, traffic accidents, tickets, that type of stuff. They usually have pretty impaired family and peer relationships and can be quite isolated. And not surprisingly, but like other psychiatric disorders, they often have higher mortality rates. There was a study in Denmark in 2013 that showed that the mortality rate, if you had ADHD compared to not, was 5.85 person years compared to 2.21 per 10,000 person years. So not an insignificant thing to have and not an insignificant thing to miss in terms of diagnoses. ADHD in adults basically comes in with like 5 general categories of symptoms. And again, this ties a little bit back to the DSM5 criteria, but it's basically inattention, impulsivity, hyperactivity, emotional dysregulation, and executive dysfunction. Now again, that's very vague, so a little bit more concretely. So the inattention symptoms can be anything from difficulty focusing on a task, prioritizing, managing their organization, completing tasks, forgetfulness, time management. All of that I feel like is pretty familiar to you guys and things that you expect to hear with ADHD. The impulsivity overlaps a little bit with some mania-like symptoms or hypomania type symptoms with like, these are often folks who are quick to quit jobs or relationships. They have a really hard time waiting their turn. They can often be impatient or interrupt. They're more likely to do daredevil activities or activities that put their lives at a slightly higher risk. And they can have some excessive spending as well. Hyperactivity is also fairly well known. People who are fidgety, restless, have to get up frequently or can't sit still through meetings, classes, or movies. Emotional dysregulation, I think, is something people don't really think about a lot, but is actually a huge part of ADHD. These folks have a really hard time dealing with emotion. They can be quite labile, almost sort of like borderline actually a bit. They can be quite irritable, they can have a lot of anger outbursts. They really can't tolerate frustration very well and don't know how to cope with those feelings. And similarly with sort of any emotion that's uncomfortable for them, they don't really know what to do with it. It sort of often comes out as these outbursts or again, sort of anger symptoms. Then probably the most nebulous one, but probably the most important is this concept of executive dysfunction. So especially as adults, they really struggle with self-directed actions, starting tasks, shifting between tasks, and sort of monitoring their own workflow. And to me, this always seemed, again, like incredibly nebulous and not very concrete. And I didn't really know how to ask patients about this. So getting back to our favorite ADHD alien cartoon, I think this is probably the best example of emotional dysregulation. So she describes it as, okay, let's clean this table. Before that, I should probably clean the sink. Wait, damn, I need to bring out the trash for that. It's 3 p.m. I can't go outside of my pajamas. I guess I should get changed. But I want to shower before putting on new clothes. But if I shower first, then I'll get sweaty. But if I don't do the sink first, I'll forget. Wait, why am I holding milk? Did I not feed the cat? And then basically her brain explodes with like thousands of questions that she can't sort through anymore. And she basically goes into full shutdown mode. And then someone walks up to her and is like, are you okay? All you have to do is clean the table. This is essentially what emotional dysregulation is. Even doing one simple task then makes them think of all the components leading up to that task and to complete that task, and they will get lost in the mess of those and then just essentially shut down and can't decide to do any of the tasks. And they won't do even something as simple as like putting away the dishes or cleaning the table because it becomes too overwhelming. Does that make sense? For those of you that don't have ADHD? Okay. I like that Hasib and Mac are agreeing that that is their real life. So the other thing I think it's kind of hard about ADHD is that really all of the diagnostic criteria was originally developed for children. And so as adult doctors, we don't really have a good way to sort of apply that to how we see our patients. But one of the key differences is adults have a lot more inattention and executive dysfunction and a lot less of the hyperactivity and impulsivity. They certainly can have those symptoms, but usually if they've made it to adulthood without diagnosis, they've been really good at suppressing or sort of managing their hyperactivity and impulsivity. And it's more the inattention and executive dysfunction that gets in the way of their professional and social circles. So getting back to what Mac brought up earlier of like, oh, if I'm going to see someone with ADHD, let's pull up the DSM-5. The DSM-5 criteria basically breaks ADHD down into inattention symptoms and sort of gives you a list here. And then some of the hyperactivity and impulsivity symptoms. And to me, those two lists more or less kind of make sense. But I feel like they have a ton of overlap with like depression, anxiety, sort of other psychiatric disorders. I don't know if you guys have looked this up, but the final like criteria for using the DSM-5 is super confusing. They want you to have 5 or more symptoms in each category, or 5 symptoms from each of the 2 categories for a total of 10 or more from the 2 categories, plus all of the things below, which is like ADHD symptoms before the age of 12. I have never met an adult that could give me that information. Current symptoms in 2 or more areas, home, school, work. Well, what if they're not in school? What if they're not working? You can't use that then. You have to have reduced quality of functioning in all 3 of those. Again, does not apply to all adults. And then they can't be explained by another diagnosis, which basically seems like a cop-out at the end of this. So I think the DSM-5 is like basically useless for adult ADHD, but if it works for you, you're welcome to use it. This is actually what I use. And for those of you who haven't investigated this yet, this is the ADHD self-reported scale. It was developed by the WHO and has some of the best sensitivity and specificity, not only as a screening tool, but as a diagnostic tool, because essentially this scale takes the DSM5 criteria for sort of the inattention and the hyperactivity and makes it into more concrete examples and has it on a rated scale. For those of you that work in a clinic that has EPIC, this scale is also under the behavioral health tab. And you can always ask your front desk staff or MAs to give this to a patient. And it's very similar to doing like the PHQ-9 or GAD-7, and probably only takes the patient a couple minutes to fill out and can be quite helpful. And essentially, if a patient scores really high on this, meaning most of their answers are sort of in the grayed out boxes, you can feel pretty confident this is ADHD. If you're not 100% sure sort of at the end of your interview and with this, another option is to use a more comprehensive interview tool that's also quite evidence-based. It's called the Diagnostic Interview for ADHD in Adults. It's called the DSM5, and I think that's because the original document was created in another language. So I'm not quite sure what the acronym stands for. But it's sort of like a more comprehensive version of the self-reported scale. It essentially asks, again, like a very similar list of the questions, like 20 or so questions, but then for each it gives examples of adulthood presentations of that question and childhood presentations of that question in a way that's much more concrete and able for a person to sort of reflect back on their childhood. And then the total score really looks at a combination of general answers, yes or no, and how many of them are symptoms in adulthood versus childhood. This is an example of one of the questions from the inattention portion. And then they also have a long list of ones from the sort of hyperactivity, impulsivity side. This is free online. Any of you guys can download it and you can literally print it off and like walk through an HPI with this for patients. If again, you feel like the self-reported scale isn't quite clear in terms of an answer. I would also strongly recommend whenever you meet these patients, trying to also give them a PHQ-9 and a GAD-7 because they often have associated anxiety and depression, and it kind of helps you sort out how much that's contributing. But it's a bit tricky because a lot of people with ADHD have pretty bad anxiety that will get better simply with treatment of the ADHD and doesn't need a separate anxiolytic to manage that. By the way, Cody, thank you for putting that in there. I really appreciate you adding the link. Okay. Pause here for a second. Do you guys have any questions about the symptoms of ADHD, the criteria for diagnosis, or the tools that I brought up so far?
Sarah, I have a quick question, which I'm guessing you might get to later. So feel free to defer. But when you're using these types of like screening tools, can you use them also during treatment to evaluate someone's response?
Yeah, that's a great question. I'm glad you brought it up because I actually don't bring it up later. But if you use these tools in someone who is medicated, you will actually see their scores go down. It's not quite as dramatic as with like a PHQ-9 or a GAD-7, where sometimes they will go down to almost 0 in terms of their scores. Even the best medicated ADHD patient still has some degree of symptoms. But it's quite dramatic, actually. With this patient that we're talking about, well, I didn't include it in the PowerPoint, his scores went down dramatically when I re-administered the test after treatment. Other questions?
Sarah, I have a question about, we hear a lot in like the media and popular culture about how there are gender differences and how ADHD manifests, and are there any like specific resources for women who struggle with ADHD or like different screening tools specifically for that population?
You literally are reading my mind, because I actually had a case of this in clinic 2 weeks ago, of a woman coming in for evaluation of ADHD, and her symptoms were quite markedly different. And she definitely didn't score as high on these tests, which were more originally developed for predominantly the male dominant symptoms. There does not currently exist a screening tool for women. But I would say, to answer your question, just because a female gendered patient scores lower doesn't necessarily mean she does not have it. In that case, the sensitivity is actually a bit lower. A lot of female gendered patients are more commonly able to cope or suppress some of these symptoms, and they can sort of manage them. I don't like to say better than men, but society sort of encourages the female gender to hide more of those characteristics. And so they will frequently not score as high. Ooh, thank you. Let's see. Now you have to come on and tell me what the Diva 2.0 is.
I have no idea what the Diva 2.0 is, but also I'm doing it, and Diva 5 costs 10 euros to download, so I did not pay that.
I can set up the link afterward for the Diva 5 that I have, just so you guys can actually have access to it, because I promise it is free online. I found a spot we can get it. How does a female patient present? Ooh, good question. Has anyone had a female patient with ADHD that they want to sort of share what their experience has been like? So generally, the impulsivity and hyperactivity is significantly more suppressed in them. Both as a child, they usually had a lot less of those issues. More, they have struggled typically with, here I'll go back to sort of my list of symptoms here. The inattention aspect, frequently being like interrupting, having trouble waiting for their turn, struggling with organization, time management, completing tasks, much more likely to have the sort of executive dysfunction. And again, because sort of the female gender is often expected to sort of hide emotion more, they're a little bit better at hiding some of the frustration that they feel. But that usually means that they then need more personal time to sort of decompress and recover from the intense feelings they have around their ADHD symptoms. Does that answer your question?
Yes.
Sorry, go ahead.
It did, thank you.
Cool. Let's see, Megan, what's your practice for prescribing, not prescribing medication for those, maybe mostly female gendered, who seem to have good coping skills for ADHD? Ooh, hold that thought. When we get to medications, remind me to come back to that, because that's a really good question.
I have one question.
Yeah.
Yeah, before we move on, one of the reasons why I think I've had some discomfort making these new diagnoses in individuals in their 20s before is that sort of the end result in some of these medications that we prescribe are sort of high risk for abuse and diversion. And I think there have been circumstances that I've encountered there that maybe I've been suspicious that there has been some ulterior motives for people kind of bringing up some of these things and, being mindful of some of the screening tools and questions that we're going to ask. And I just want to put that on the table, and I'm curious how you approach that undercurrent sort of underlying some of these interactions.
Yeah, no, and I will also plan to get to that. That was Jesse, right?
Yes.
Okay, cool. Thought I recognized your voice. I can't see everyone's name, so I just wanted to make sure I had the right person. So my answer for that is for patients that I kind of get a weird vibe on, that I'm not 100% sure that they really have ADHD, that they're just sort of saying yes to everything because they want a stimulant, or they sort of want the diagnosis, or so they want the medication to sort of make their life easier, or like you brought up the concern around diversion. Those are people that I don't give stimulants to right away. And we'll get to some of the non-stimulant options. Those are also sometimes the people that if they decline the non-stimulants or sort of don't have good luck with the non-stimulants, I might actually get a psychiatrist to sort of help me out, even like sort of a one-time evaluation to be a bit more comprehensive and make sure I'm not missing something, but I'm much, much more careful about stimulants with them. And I have a specific example I can bring up from my clinic. But I'll come back to that, I promise, when we get to medication management too. And then John said, Sarah, how would you respond when someone comes in at an older age, like greater than 50, with concerns about ADHD and never been diagnosed? Anything different? So the diagnosis is more or less the same. I typically find older folks have a much harder time thinking back to their childhood, which is why these scales that are a bit more adult focused are a little more useful and thinking more about sort of the inattention and executive dysfunction and less the hyperactivity and impulsivity. I have a few patients on my panel that got diagnosed actually in their 50s. Usually I ask a fair amount about why they're seeking the diagnosis now. Is there something about this that is just now coming to a head, meaning that like now it's really starting to affect their personal life or their jobs, or sort of retroactively they're seeing that as a pattern? Again, John, those are people that I'm really resistant to do stimulants in, mostly because we don't have good data that stimulants are super effective at people older in life, and that they often have a lot of cardiovascular side effects. So we'll often sort of compromise more with the non-stimulants. And if they're really having a pattern of like difficulty with functioning in society, those are another good one to be like, well, maybe I should get a psychiatrist before I think about a stimulant for them. John, does that answer your question? Yes.
Yep.
Okay.
Thank you.
And then Jesse basically got to my next slide, which is like spot on, which is, ooh, Nick has another one. Can you speak diagnosis in someone with co-occurring substance use disorder? Yes. Nick, what substance use disorder?
I'm thinking specifically of a patient that I have who was on a stimulant for adult onset ADHD, but also is using meth.
Excellent question. So sort of going by less harmful drugs to potentially more harmful drugs. I don't really care if they're using marijuana, whatever, it's legal in Washington state. Alcohol, again, in moderation is fine. If it's like high amounts of alcohol, they're basically sort of doing stimulant and then downer, and that's sort of concerning. Benzos for me are hard no, because again, it's really trying to use a downer to counteract a stimulant. I don't really like doing that unless, again, they have something like borderline or an advanced psychiatric diagnosis, and I'm sort of working with their psychiatrist to manage the ADHD. If they're using methamphetamines, I don't typically continue to prescribe meds for ADHD if they were sort of on them previously. However, the one caveat is if they're willing to come off methamphetamine illegally to do stimulants with me, I'm actually open to that idea. And I've done that for a few of my patients who had heroin use disorder, sort of recover from that with Suboxone or methadone, but really still struggle with the methamphetamine use. And sort of in taking a history from them, it seems much more like they're kind of just self-medicating their ADHD as opposed to just using it as an upper side effect of the downer. And those are folks that I'm willing to try like very low dose stimulants. Again, the caveat being they can't use meth on top of it. And if they're willing to sort of do that with me, and we can see that difference in their drug UAs, then I'm happy to do it for them. And it's actually not as hard as you think to prescribe a stimulant for patients in like a methadone maintenance program, as long as you talk with their program. Stimulant plus heroin use disorder, again, not a hard no for me, but I again really, really want to push them to stop using IV heroin and do more like Suboxone or methadone with me. Does that answer your question, Nick?
It kind of answers my question. I guess I'm more thinking like, do you think it's to diet I feel like a lot of the symptoms of like the executive dysfunction, emotional dysregulation, and a lot of that stuff just be caused by the substance use. And so I don't know, how do you just try to tease that apart as best you can? And
yeah, it's a little bit patient specific, which is like the worst thing to say when you're trying to do a lecture about making things easier for you guys. For the most part, people that use methamphetamine, I feel like they kind of sort of fall into two categories. Either they're, again, self-medicating it for the stimulant benefit, for whatever reason, professionally, personally, they sort of want that upper. Obviously, we know our folks with heroin use disorder sort of use it to counteract the downer effect of the opiate. And there's a population that basically never got diagnosed with ADHD and are using it, again, to treat their ADHD. And they never really had good access to a psychiatrist or counselor, primary care doctor to sort of help them get diagnosed earlier. That one takes probably the most effort sort of exploring back to childhood and to why they sort of started using it in the first place. And there's one thing we're going to get to at the very end of this, which is there is a key difference by how stimulants affect people with ADHD versus non-ADHD, and you can use it in those moments. There's a question we can basically ask because the medication has a very different effect on a brain with ADHD than it does on a brain without ADHD. And I will give an example of that when we get to the end. So stick with me, Nick, I promise.
Thank you.
And again, if you look online, there's not actually good evidence for using stimulants for methamphetamine use disorder, but if you're safe about it, it isn't completely off the table as a possibility. We just haven't studied it enough yet to know if it actually works. Okay, Brian, do you view underlying hypertension, heart disease, CKD as a relative or absolute contraindication? Ooh, heart disease, hypertension, hard no for me for stimulants, unless prescribed by a psychiatrist. Again, because the risk of worsening cardiovascular disease is quite dramatic, but the non-stimulants are an option. CKD is actually only one medication that has to be renally dosed, and we'll go over that when we get to the medications. Man, you guys are so engaged. This is so wonderful. Anisha is including a clinical trial from Harborview. Ooh, excellent. So methamphetamine for meth use actually may help with it. Awesome. We need more of that research because, I mean, if we're prescribing people opiates for opiate use disorder, why can't we prescribe them stimulants for stimulant use disorder? I know it's probably because they're, you know, not quite like Suboxone where there's a cap on them, but I'm really excited to hear more about that research. I'm gonna have to read that study. And then Arita asked, is there any evidence for increased cardiovascular risk for those without cardiovascular disease? Yes. So that's always a trade-off with stimulants is there's always an increased risk of cardiovascular disease that depends on how many years you're on the stimulant, what dose of stimulant, and the age essentially that you currently are at. My general practice is once people are sort of getting to their 50s, even if they have no cardiovascular disease, it's a risk benefits conversation, kind of like sleep aids in older folks. If they're younger with cardiovascular disease or sort of developing cardiovascular disease, I might have that conversation much sooner. And the compromise is always you can go down on the dose, or you can think about switching them to a non-stimulant. I hope that answers your question, Arita. Okay, so why are we afraid to diagnose ADHD? Well, you guys just brought up many of the reasons, which is really helpful to hear. For me, it was always, do I have the correct diagnosis? Because like I brought up before, there's a lot of overlap with anxiety, panic disorders, mania bipolar, and as sort of Nick appropriately pointed out, substance use disorder. It's really hard to know exactly if you're getting that right. There's also a big overlap actually with autism spectrum too. Many of us have sort of heard about the patients, as Stephanie Hampton says, who just want a bit of a pep in their step. They just want to feel a little better, have a little more energy, be a little less tired, ace their, you know, step one score, whatever it is. And that's really not the ideal population to prescribe to. And then again, as Nick brought up, sort of more the drug seeking or drug diversion type behavior. And these are sort of always the trade-off. I have to say, at least personally, although again, I have primarily a Roosevelt population, I've only had one patient I've ever been a little bit concerned about diversion in, and have never had too much of an issue with that. But I know it's definitely a risk, especially when this is something that you do regularly. Okay, back to our patient, this 25-year-old. Do you guys think he has ADHD? We're gonna put a poll up here for this.
Sarah, is it too hard to show the symptoms on your earlier slide?
Not at all. I can easily go back to that. Thank you for asking, John. There you guys go. All right, looks like we have about, oh, we're still having like votes rolling in. You guys are great. All right, we've got 46 of 67, so I'm gonna go ahead and call it. So it looks like 41 people thought yes, and 5 people thought no. Let's start with one of the yes people. Would someone be willing to share why they think this patient has ADHD, sort of what tipped it over for them? Also, I know all of your names and I can start picking out random people from the audience.
I
don't know. Well, you can go.
I voted yes because it does seem like he has a lot of these symptoms of sort of, inattention, impulsivity, moving to India, requiring and some like other like self-medicating to try to manage this. And sort of fundamentally for me, it seems like it's really affected his life and his ability to function socially and professionally.
Yeah. How about someone that said no? What made you still sort of a little wary in this case? And there, again, there's many reasons always to be wary in these cases. There's only 5 of you, so it's a bit harder to guess who that might have been. Okay, there's no brave folks from the 5%, or sorry, the 11%. I would say it is actually very reasonable still to question this, right? He might certainly have something else, like maybe he has bipolar, and maybe these are sort of intermittent symptoms of hypomania. Maybe he just has really bad untreated anxiety, depression, doesn't really sort of fit well in the traditional structure of school. Maybe he has a learning disability. Or again, maybe this is more like borderline, or maybe this is just his personality. He's actually not that unhappy with who he is, and maybe this college thing just isn't quite the right fit. So again, not unreasonable to question it. So let me give you his scores. So his self-reported data, sort of classically in the adult fashion, he got 22 out of 24 for inattention. And for the hyperactivity portion, he got 34 with over 48, which is generally consistent with diagnosis of ADHD. His PHQ-9 was, I think, like 5. It was pretty low. And his GAD-7, I think, was probably like 8 to 10, something like that. And from my perspective, I thought it was really reasonable to consider a diagnosis of ADHD and potentially to consider treatment for him. Again, there's no right or wrong here, and it's always reasonable to reach out to a psychiatrist if you're like, I'm just not 100% sure with this case. So if you really don't want to do a medication, which is also very reasonable, there are lots of non-pharmacologic options for management of ADHD. They're a little harder for sort of us to teach, but something these patients can reach out to, and there's many good resources online and good books about this. But really the key things that they need to do are regular, surprisingly overly detailed calendars, really detailed to-do lists, structured daily routine, making sure they actually sleep as opposed to staying up all night. Exercise is really good for burning a lot of energy, and a lot of people use that essentially to medicate it. Counseling is really important, particularly CBD has really good evidence for ADHD. And then for those that are struggling with school or with work, some type of like career counseling or social work support can be really helpful. And then if they don't want to do medication, and even if they do, it's really important for those that are in school or work to reach out to disability services to get accommodations. And you guys in particular can really help with that one through doctor's letters and doctor's evaluations. If you're thinking you want to do more medications, like I brought up earlier, there's basically 2 categories. One is stimulant and one is non-stimulant. For the non-stimulants, one you guys know really well, which is bupropion or Wellbutrin. And then the other that you guys can prescribe is atomoxetine or Strattera. Strattera is a bit stronger than the Wellbutrin, but both can be effective, again, depending on the patient. And then there's stimulants, and there's actually tons of stimulants, but they're basically all just some iteration of these 3. Methylphenidate in immediate release or extended release. Adderall, which is dextroamphetamine and amphetamine mixed salt. And again, that comes in IR, ER, and then Vyvanse, which is sort of an atypical one that's out there. There's a few others that aren't typically prescribed by us that are available, but these are really the key ones that you guys would ever need to know and use. Bupropion, I think most residents are fairly familiar with. This is our dopamine norepinephrine reuptake inhibitor. In terms of dosing, just don't bother with the immediate release or sustained release. Nowadays, most insurances will cover the extended release, and it's really the most effective and easiest to take. And it basically comes in 150 milligrams to 450, with most people being fairly therapeutic at about 300. You guys also know the side effects of this: weight loss, insomnia, headaches, GI symptoms, really vivid dreams, and it lowers seizure threshold and lowers alcohol tolerance. So not always the best option in folks who also have like alcohol use or alcohol use disorder. And then Strattera is a selective norepinephrine reuptake inhibitor, and basically comes in 40 to 100 milligram tablets once daily. There is a 100 milligram one if you really need it, but not much evidence that that additional 20 milligrams does very much. Pretty similar symptoms, pretty mild: headaches, insomnia, dry mouth, some GI stuff. Can cause erectile dysfunction in men, and it does need hepatic adjustment for hepatic impairment. And then your stimulants. So methylphenidate is an often favorite of mine, and some of its brand names are Ritalin or Concerta. And it comes in basically 10 milligram to 60 milligram short-acting tablets, which you can give twice a day or 3 times a day. My caveat around the dosing is when you prescribe this, it should actually be 1 dose in the morning, 1 dose 4 to 6 hours later. Has the most efficacy for sustained action over the course of the day if the second dose is not really a BID dose, but more of a like 4 to 6 hours, like around lunches. As expected, most stimulants cause dry mouth, insomnia, decreased appetite and weight loss. They can cause anxiety and palpitations. They can affect cardiovascular health. They can give you headaches and make you irritable and have a fair amount of jitteriness. Adderall comes very similarly to methylphenidate in the short-acting form of 5 milligrams to 60, same sort of dosing frequency of a dose in the morning and a dose 4 to 6 hours later, and you can do up to 3 in a day. Has basically the exact same side effects as methylphenidate, but they're much more intense than they are with methylphenidate. And then Adderall has a bit higher risk than methylphenidate for MI, and particularly Raynaud's phenomenon. And then Vyvanse is kind of like a really cool long-acting stimulant that people tolerate actually very well. It's just hard to get it approved by insurance. It comes in 10 to 70 milligrams. 20 is a pretty typical starting dose. It's extended release only, and it has pretty much some of the least cardiovascular side effects for all of the stimulants, but this is the one that you have to be careful in CKD because it needs renal adjustment. Let's see, John said, kids are often given a Ritalin holiday over the weekends because of weight loss. Do this for adults? Yeah, actually a lot of my adult patients don't take it on weekends and really only take it when they're like in school or need it for work. And that's one advantage of sort of the stimulants is they're more short acting, so you can sort of decide when you want them and when you don't. And that can help really counteract some of the side effects. Brian, any head-to-head trials? So you're sort of getting to my next slide. You guys are so good today. The stimulants are more effective than the non-stimulants, and typically atomoxetine is a bit more effective than bupropion. So it's sort of a scale up in terms of strength of medication, which actually makes it really easy to pick what seems most appropriate and to scale someone up. Millette, I've seen bupropion used for overlap of depression and ADHD, but often those patients already have headaches and insomnia. Do those symptoms improve or get much worse? Actually, they often improve, primarily because a lot of the insomnia is sort of a secondary effect to the untreated depression and ADHD. As long as you're taking it in the morning, it doesn't cause nearly as much insomnia as the stimulants. And it rarely makes headaches significantly worse. I would say it might affect their insomnia though, because it does actually cause surprisingly vivid dreams. But it would not be a terrible option for those folks. As I brought up earlier, basically these are hardcore contraindicated in cardiovascular disease, severe hypertension, hyperthyroidism, and glaucoma for your older folks. And then just real quick, and then we'll sort of wrap up here. I want to make sure we get our interns to intern report in 15 minutes. So I'm going to skip over this question that I was going to ask here, which is essentially what medication would you pick for this guy? And the long and short is there's actually no right answer, except that sometimes insurance limits your options. There's basically two approaches, particularly around a 25-year-old who has low cardiovascular risk. You could start with a non-stimulant and work up to stimulants, or you could start with an immediate release stimulant and sort of work up to extended release dose. What I mean by that is basically this is my approach to choosing medications. If the patient and I want to start non-stimulant, either by their preference or my concern for a stimulant in them, I'll do bupropion. That doesn't work, go up to atomoxetine. That doesn't work, then go up to stimulants. If they're a young person and I think that stimulants sound very reasonable, it's sort of a slam dunk diagnosis, I'll typically sort of go straight to methylphenidate and then sort of work up to either the extended release, or if that's not effective, go to Adderall, which is the strongest, and then eventually work to extended release. Vyvanse is kind of just like a wild card. You're always welcome to try it. It actually probably is the most effective with the least side effects, but again, hard from an insurance standpoint. And typically I'll start people on immediate release till I kind of find their sweet spot in dosing, and then move to extended release if they would like to do that. The last big thing before the interns leave is this is the key point to know if someone has actually ADHD or not. And it works most effective with the stimulants, so don't tell your patients this. The medication will have the opposite effect of what you expect. If you don't have ADHD and you take a stimulant, you will feel like the Energizer Bunny. I may have borrowed once my partner's Adderall for a long call in the NICU, and holy crap, I had so much energy. I was up all night. I was so focused. I was working from 8 p.m. to 8 a.m. and I was really cheery on post-call rounds. I felt the best I'd ever felt in my entire life. I don't have ADHD. For those actually with ADHD, you take a stimulant, it calms you down. You feel sort of serene, peaceful, finally sort of able to work, and it is quite a dramatic change in sort of their hyperactivity and the activity of their brain. They're really calm, relaxed, and much more just like a normal person. So that's like the most important thing to differentiate between sort of substance use, med seeking, sort of pep in your step, and then more the true diagnosis. Okay, just sort of wrapping up here. So big take home points. There's basically 5 characteristics of ADHD: inattention, impulsivity, restlessness, and emotional dysregulation, as well as executive dysfunction, and it should impact multiple aspects of people's lives. It is not just sort of the classic squirrel reaction of like being distracted. It's much more complicated than that. You can use these 2 scales, the self-reported scale or the diagnostic interview of ADHD, to help with the diagnosis. Medication options come in non-stimulant and stimulant varieties. And if it's really ADHD, people should feel calm on the meds, not like an Energizer Bunny. References that will be in the PowerPoint for later. And then I want to make sure the interns can get off in 2 minutes before their mega report. Any burning questions from the interns first, and then if not, then from our senior residents. All right, let's see here. John, how is that different from how you are normally? Fair point, but trust me, I was much more energetic on Adderall than I was off of it. Ariel, does this apply to Wellbutrin or just to STIMIs? Oh, I like the phrase STIMIs. So the effect is most dominant with stimulants as opposed to bupropion or atomoxetine. That doesn't really seem to have quite the same degree of effect, again, because they're quite milder medications. But if you're thinking about prescribing a stimulant and you're kind of worried, you can really use that as differentiating factor between true ADHD and not ADHD. Does that answer your question, Ariel? Okay, let's see. Any other questions? You guys are being very nice in the comments. Let's see, Nick said, you mentioned patients with ADHD and anxiety. Do you see the same effect of a paradoxical effect with stimulants versus exacerbating anxiety? Good question, same paradoxical effect. People with ADHD often have a fair amount of comorbid anxiety, but most of it is actually around their ADHD symptoms and the effect that that has on their functioning. So you put them on a stimulant, it actually makes them much calmer and less anxious. And that's why often it's most effective to try an ADHD medication before like an SSRI or an anxiolytic, because typically it will fix the anxiety more often than not. Sometimes not 100%, you may want to add that on later, but I would always try the ADHD meds first. If it makes them more panicky or more anxious, again, they probably don't have just pure ADHD, and I'd be quite worried that they have either no ADHD or pretty significant like panic disorder associated with it. Does that answer your question, Nick? Okay, other questions? From seniors only, interns get out of here.
Yeah, interns, we love you, but please leave. Go learn about cirrhosis and then come back and tell us about it later. I think if people want to keep hanging out and answering questions, that's great. But if anyone needs a break, we'll take about 5 minutes before we start our next session too. So I think feel free to hang out and chat, but also grab coffee, do what you need to do.
Thank you, Lauren.
Thanks, Sarah. Thanks for these. This is super helpful. I feel like we really needed this talk. So that was great.
I will send it to you to put on the website afterwards.
Well, great.
And if anyone has any specific questions about the talk that I didn't get to or about specific cases and patients, please feel free to email me. You guys all still have my email. It's steinkruger@uw.edu. And thank you for having me on.